The clinical approach to chronic pain is undergoing a necessary and overdue transformation. For decades, the medical establishment has viewed obesity and pain through a binary biomechanical lens. We were taught that excess weight simply places mechanical stress on joints, and if we could just reduce that load, the pain would resolve. This view is insufficient and frankly dangerous. Modern pathophysiology confirms that chronic pain is a distinct disease state driven by systemic metabolic dysregulation. We are not treating mechanical load, we are treating a metabolic environment that has drifted out of balance. This shift dictates whether a practitioner prescribes a joint brace for stabilization or a metabolic intervention for inflammatory resolution. The urgency is underscored by a global crisis. In the United States, nearly 93% of the population has metabolic dysfunction, and 25.4% of adults experience chronic pain. Historically, we have relied on the pharmacological suppression of symptoms via opioids, leading to a devastating epidemic. Identifying the underlying inflammatory drivers of pain is no longer an academic pursuit. It is a clinical necessity to reduce dependency and improve functional outcomes. We must define the underlying pathology, which is meta-inflammation. This is a chronic, low-grade inflammatory state. It is not an infection. It is a sterile response to metabolic stressors. It does not resolve on its own. It eventually causes direct organ damage and sensitizes the nervous system. The primary drivers here are adipose tissue macrophages. In a healthy, lean state, these cells support homeostasis. In the presence of overnutrition, they transition into a pro-inflammatory phenotype. They form crown-like structures around dying adipocytes, becoming focal points for systemic signaling. Once polarized, these macrophages secrete a potent pro-inflammatory secretome, including cytokines like TNF-alpha, IL-6, and IL-1-beta. These molecules prime the patient for hyperalgesia, engaging receptors on nociceptors and lowering the threshold for pain. The triggers for this state include sterile stimuli that generate damage-associated molecular patterns, or DAMPs. This includes metabolic stress from excess lipids and glucose, and endoplasmic reticulum stress from adipocyte hypertrophy. This environment transforms visceral fat from a storage depot into a specialized endocrine organ that targets the nervous system, reinforcing pain sensations through continuous nociceptor activation. We have to distinguish between fat quantity and quality. The obesity paradox shows us that a high BMI does not always correlate with pain. Some individuals with a lower BMI still face significant risk due to visceral adiposity. Visceral fat is the real threat. Its venous drainage flows directly into the portal vein, hitting the liver immediately. This allows inflammatory signals and leaked fatty acids to impact hepatic function. The liver is the primary site of C-reactive protein production in response to IL-6 released from visceral fat. This cascade escalates the systemic inflammatory load that sensitizes the central nervous system. Furthermore, hypertrophic adipocytes develop a senescence-associated secretory phenotype. They leak fatty acids and summon pro-inflammatory immune cells, transforming healthy tissue into a source of systemic metabolic crud that drives vascular disease and chronic pain. Adipose tissue acts as a significant endocrine organ, producing adipokines, which are active neuromodulators. Leptin limits food intake, but engages immune receptors to create a pro-inflammatory bias and lower the pain threshold. Adiponectin, which is anti-inflammatory and enhances insulin sensitivity, is downregulated in obesity. This removes a key anti-inflammatory brake. Asparagine, involved in glucose metabolism, is specifically linked to fibromyalgia syndrome and widespread pain. We also see sex hormone dysregulation. Visceral fat utilizes aromatase activity to convert testosterone to estrogen. This leads to hypogonadism in men and insulin resistance-driven PCOS symptoms in women. This hormonal imbalance perpetuates inflammation and complicates recovery. Systemic cytokines cross the blood-brain barrier and induce neuroinflammation. This triggers a glial feed-forward loop, where activated microglia and astrocytes release neuromodulators that increase the sensitivity of nociceptors. This results in allodynia, where even non-painful stimuli become excruciating. BMI is a flawed diagnostic tool. It fails to identify the visceral compartment. As clinicians, we must shift to metrics like the metabolic score for visceral fat, or METS-VF. This index incorporates fasting glucose, triglycerides, HDL-C, BMI, age, and waist-to-height ratio to provide an accurate prediction of chronic pain odds compared to BMI alone. We must also monitor HSCRP for systemic load, fasting insulin for early metabolic dysfunction, and HbA1c for long-term glycemic control. These markers are critical because systemic inflammation blunts the protective effects of vigorous physical activity. In these patients, the analgesic dose of exercise is effectively neutralized by the metabolic environment, making traditional physical therapy less effective until meta-inflammation is addressed. Management requires metabolic restoration. This is not about opioid suppression, it is about cooling the fire. Dietary patterns should focus on microbiome health. The Mediterranean and DASH diets are rich in fiber. The gut microbiota ferments into short-chain fatty acids like butyrate and propionate. These fatty acids suppress orexigenic neurons and modulate gut-brain communication to cool the systemic inflammatory environment. Nutrient-specific inhibition is also required. Omega-3 fatty acids lower the omega-6 to omega-3 ratio to resolve chronic inflammation. Curcumin potently inhibits NF-kappa B and COX2 pathways. Vitamin D and magnesium regulate the immune response. They act as natural NMDA receptor antagonists to modulate central pain. We must also address the cortisol and sleep connection. Chronic stress drives fat into the visceral compartment via lipoprotein lipase activation. High-quality, circadian-aligned sleep of 7 to 8 hours is essential to lower IL-6 and CRP. Clinicians must recognize that stress reduction is not a luxury. It is essential metabolic work for pain resolution. Pharmacologic frontiers include metformin, which decreases NF-kappa B expression, GLP-1 agonists like semaglutide that increase protective adiponectin, and SGLT2 inhibitors that downregulate systemic cytokines. These medications target the inflammatory source rather than just masking the output. Meta-inflammation is the bridge between visceral obesity and chronic pain. By treating visceral adiposity as a complex endocrine disorder, we break the cycle of systemic sensitization. The current limitation of nutrition education in medical schools, averaging only 19 hours, must be addressed. We need to integrate clinical nutritionists into our pain clinics. We must provide advanced training in metabolic health for pain specialists. We need to shift focus and treat visceral adiposity as a metabolic endocrine disorder. We must use METS-VF and VAI rather than BMI. The evolution of pain medicine toward metabolic health offers the most viable hope for improving long-term patient outcomes and moving beyond the limitations of the opioid era.